Welcome to Rad Onc Smart Review RadBio edition.
Hello, everyone.
Today we're jumping right into a really core topic, tumor kinetics. So basically how fast tumors grow and what drives that speed.
Exactly. We'll be breaking down some key concepts like potential doubling time, Tpot growth fraction, or GF, and the cell loss factor, phi.
Right. Think of it like understanding the engine, the fuel, and maybe the brakes on how a tumor actually grows.
And critically, how this all ties into accelerated repopulation, which is, a huge factor when we're planning and delivering radiotherapy.
Yeah, definitely. And this really builds on things we've touched on before, the cell cycle, radiosensitivity, even techniques like percent-labeled mitoses and flow cytometry.
Right. Having that background will hopefully make today's discussion click even better.
So where do we start if we want to measure how fast this tumor engine is running?
Well, a good starting point is measuring cell proliferation directly.
Right.
And the first metric we should probably talk about is the labeling index, or LI.
Okay, LI. So this is like taking a snapshot of the tumor, right? It tells us what percentage of cells are actively making DNA in S phase at that specific moment.
Precisely. Like seeing how many factory workers are actually busy on the assembly line right now. Those are your S-phase cells.
And how do we actually see them? We use those special markers.
Yeah, we use thymidine analogs. Think of them as like a special ink that early cells copying their DNA will pick up. The common ones are brondeoxyuridine, BRDU, and iodeoxyuridine, IUDR.
Okay. So you give the tumor a quick pulse of this BRDU, for instance.
And only the cells that happen to be in S phase during that short pulse will incorporate it into their new DNA strands.
Then you use fluorescent antibodies that stick specifically to the BRDU.
Exactly. And then you can count them using flow cytometry, or just look under a microscope to see which cells lit up.
So the calculation is pretty straightforward then.
Yeah, it's just the number of labeled cells, the ones that took up the BRDU, divided by the total number of cells you counted, then multiply by 100 to get a percentage.
And a higher L means?
Generally, it means faster proliferation. Often an LI of, say, 10, 15% or more is considered pretty rapid. It's a direct look at how many cells are actively gearing up to divide.
Okay, that makes sense. So LI is the current activity. What about the potential speed, the theoretical maximum?
Ah, right. That brings us to potential doubling time, or Tpot.
Tpot. This is the time it would theoretically take for the number of actively dividing cells to double. Correct. But it assumes no cells are lost.
Exactly. It reflects the tumor's pure intrinsic proliferation speed. It's like the engine's top speed on a test track, ignoring friction or breakdowns, and it's really critical when treatments stretch over time.
I see there are a couple of ways to calculate it. One involves the total cell cycle time, TC.
Yeah, and the growth fraction, GF, which we'll define properly in a minute, that formula is Tpot equals TCGF.
Which kind of makes sense intuitively. If only a fraction GF are dividing, the doubling time for that pool is longer than one cell cycle time.
Right. But the formula you'll probably see more often, especially, for exams and practical use, involves the labeling index we just talked about.
Okay, what's that one?
That's Tpot equals lambda TSLI.
All right, let's break that down. TS is just the duration of the S phase. How long DNA synthesis takes?
Yep. LI, we already know the fraction in S phase. And lambda, that's a correction factor.
A correction for what?
It accounts for the fact that the dividing cells aren't all perfectly synchronized. There are different points in the cycle.
Yeah.
So lambda corrects for that age distribution.
Okay. And what kind of value does lambda usually have?
Well, it depends on the exact distribution, but it's often around 0.8 if we don't know. It can range from about 0.7 up to 1. For board exam purposes, sometimes they'll just tell you to assume lambda is 1 to keep the math simple.
And we can actually measure TS and LI.
We can, using flow cytometry again. If you use BRDU labeling and stain for total DNA content at the same time in the dual parameter flow, you can estimate both TS and LI from the same sample.
That's pretty powerful. So a short Tpot, maybe just a few days, signals a tumor that's intrinsically programmed to grow fast.
Exactly. And that has big implications for radiotherapy scheduling, which will definitely circle back to this idea of accelerated repopulation.
Okay, so we've got LI for the snapshot of S phase, Tpot for the potential doubling speed. What about the growth fraction you mentioned earlier, GF?
Right, GF. This tells us what proportion of all the cells in the tumor are actually in the active cell cycle, so G1, S, G2, or M phase.
As opposed to the cells that are just resting.
Exactly. Versus cells in G0, which is a quiescent state, or cells that have terminally differentiated and won't divide anymore.
So the formula is GFS equals P plus Q, where P is proliferating and Q is quiescent.
Perfect. It's the fraction of the tumor that's actively trying to make more tumor cells at any given time.
And how do we estimate that in practice? Is it similar to LI?
Well, some methods are similar. Pulse labeling with BRDU gives you the LI, which is related to GF, but isn't quite the same thing because LI only counts S-phase cells.
Right. GF includes G1, G2, and M2. So what else?
There's continuous labeling. You expose the tumor cells to the label, like tritiated thymidine, for a longer time, roughly TC minus TS.
Ah, so you give enough time for most of the actively cycling cells to pass through S phase and pick up the label?
Exactly. The fraction labeled after that longer period gives you a much better estimate of the actual growth fraction.
Okay. Is there another common way?
Yeah, probably the most common method you'll see in pathology reports or research is Ki-67 staining.
Ah, Ki-67. Ki-67. That protein is only expressed in cycling cells, right?
Correct. It's found in G1, S, G2, and M phases, but crucially, not in G0 resting cells. So the percentage of cells staining positive for Ki-67 is often used as a pretty good surrogate for the growth fraction.
And what sort of numbers do we typically see for GF? Is it usually high?
You might be surprised. In experimental animal tumors, it's often somewhere between, say, 30% and 70%.
So a really significant chunk of the tumor might not be actively dividing.
Exactly. Even in tumors that are clearly growing, many cells can be quiescent or differentiated. And this fact that not all cells are dividing, and the GF isn't 100%, is one reason why tumors often grow slower than their Tpot suggests.
Which leads us perfectly into the next piece of the puzzle. Cell loss.
Precisely. The potential doubling time, Tpot, is often way shorter than the time we actually observe it takes for a tumor's volume to double. And the reason is cell loss.
So we need a way to quantify that loss. That's the cell loss factor phi.
Yep. Phi measures the rate of cell loss relative to the rate of new cell production.
And the formula involves Tpot and?
And TD, the tumor volume doubling time. The formula is phi equals 1, Tpot TD.
Okay, so TD is the one we actually measure in the patient or animal, like watching the tumor grow on scans or with calipers.
Exactly. TD is the real-world observed doubling time of the tumor's volume.
So phi tells us how the actual doubling time TD is slowed down compared to the potential Tpot due to cells being lost. What's the range for phi?
It goes from 0 to 1 or 0% to 100%.
If phi is 0?
That means Tpot equals TD, no cell loss at all, which is, pretty rare in reality.
And if a phi is high, say 0.9?
A phi of 0.9 or 90% means that for every 10 new cells the tumor produces, 9 are lost through various mechanisms. Only 1 out of 10 actually contributes to the net increase in tumor size.
Wow. 90% loss, that's huge. It explains why TD can be so much longer than Tpot in human tumors, then.
Absolutely. TD in human tumors is often measured in weeks or months, whereas Tpot might only be a few days. The difference is massive cell loss.
What causes all this loss? Where do the cells go?
A lot of factors. Poor blood supply is a big one, leads to hypoxia, lack of nutrients, and ultimately necrosis, especially in the center of larger tumors.
Programmed cell death, too. Apoptosis.
Definitely. Apoptosis is a major route. Also, other forms like necroptosis. The immune system can attack and kill tumor cells. Cells can metastasize, leaving the primary tumor.
And for some tumors, like skin or lining surfaces?
They can just be shed or exfoliated from the surface, so lots of ways for cells to be lost.
And this phi isn't constant, right?
No, it varies a lot between tumor types, and it often increases as a tumor gets bigger and outgrows its blood supply. It can easily be 70, 80, even over 90% in many human cancers.
Okay, so we have this dynamic picture. Potential for rapid growth, short Tpot, but often a low fraction actually dividing, GF, and massive cell loss, high phi, leading to a slower observed growth, PD. How does radiation therapy interact with this, especially this idea of accelerated repopulation?
Right, so when we start treating a tumor with fractionated radiotherapy, we're killing cells. But the surviving tumor cells don't just sit passively waiting for the next dose.
They can fight back, essentially.
In a way, yes.
Yeah.
They can start dividing faster than they were before treatment started. That's accelerated repopulation. The tumor tries to regrow more quickly in response to the injury we're causing.
What triggers that speed up? Is it just fewer cells competing for resources?
That's part of the thinking. Killing cells might reduce contact inhibition, increase available nutrients or growth factors, or remove negative feedback signals. This could prompt the remaining viable clonogenic cells to shorten their cell cycle time and just proliferate faster overall.
And is this something that happens right away from day one of treatment?
Usually not. There seems to be a lag phase. The tumor has to sort of recognize the damage and then kickstart this response.
So when does it typically become a clinical issue, say in head and neck cancers, where it's well studied?
For many head and neck cancers treated with standard fractionation, it's thought to become significant around the 4th or 5th week of treatment.
So about 28 days in.
Roughly, yeah. Around that point, in a typical 6 or 7 week course, the repopulation rate might really pick up speed.
And the consequences, we lose ground.
Effectively, yes. If the tumor starts regrowing faster between fractions, each gray we deliver becomes less effective at achieving net cell kill. We might need to give a higher total dose to achieve the same level of tumor control if the treatment drags on too long after this acceleration kicks in.
How much extra dose are we talking?
It's estimated, again for head and neck, that for every extra day of treatment beyond that 4 to 5 week point, you might need something like an extra 0.5 to 0.6 gray to compensate for that accelerated regrowth.
That really adds up. It underscores why treatment breaks are bad and why shortening the overall treatment time might be good.
Exactly. It's the key rationale behind accelerated fractionation schedules, especially for tumors suspected of having rapid proliferation kinetics.
Okay, let's connect this to clinical decision-making then. If you have a patient whose tumor shows signs of rapid proliferation, maybe a high LI, or you estimate a short Tpot, what goes through your mind regarding treatment?
Well, if you see a high LI, say over 10 or 15%, and you estimate or measure a short Tpot, maybe less than 4 or 5 days, that's a big red flag.
Red flag for?
For significant accelerated repopulation becoming a problem if you use a standard prolonged treatment course. In those cases, especially in head and neck cancer, you'd strongly consider an accelerated fractionation schedule.
Meaning higher dose per fraction or multiple fractions per day?
Either or both. The goal is to shorten the overall treatment time, get the total dose delivered before that repopulation really undermines the treatment effect.
Okay. What about growth fraction? Does GF directly influence the radiation dose?
Not directly for dose prescription, no. But if you knew the GF was very low, it might make you think twice about the effectiveness of certain concurrent chemotherapies.
Because they target cycling cells.
Right. Cell cycle-specific agents might be less effective if only a small fraction of cells are actively cycling. You might lean more heavily on radiation or choose chemo agents that work differently.
And cell loss factor, Phil, how does that play in?
Phi helps explain the observed growth rate, why TD is long despite a short Tpot. It tells you the tumor is inefficiently growing. While radiation still needs to overcome the net growth, Phi itself doesn't really dictate the fractionation schedule like Tpot does. We still need enough dose to kill the clonogens that are surviving and proliferating.
Got it. So Tpot is the key kinetic parameter driving decisions about acceleration.
Primarily, yes, along with LI as an indicator.
All right, let's shift gears slightly. Time for some clinical pearls, the key take-home messages. Pearl number 1.
Okay, Pearl 1. A high labeling index, maybe 10–15%, usually means a short Tpot and suggests a more aggressive, rapidly proliferating tumor. Keep an eye on those.
Pearl number 2.
Pearl 2. If you see a big gap between the calculated potential doubling time, Tpot, and the observed tumor volume doubling time, PFIA, that signals a high cell loss factor. It tells you a lot of cell production is being wasted, essentially.
And pearl number 3.
Pearl 3. Understanding Tpot is absolutely critical for thinking about accelerated fractionation. Short Tpot tumors are the ones most likely to benefit from shorter overall radiation treatment times to beat accelerated repopulation.
Excellent. Now let's test ourselves with a quick board blitz. Ready?
Let's do it.
Question 1. The labeling index, LI, measures the fraction of cells in which phase? A, G1, BS, C, G2, DM.
That's got to be BS phase. LI is all about DNA synthesis.
Correct. Question 2. Calculate Tpot if lambda 1 TS equals 10 hours and LI equals 20% or 0.2. A, 20 H's, B, 40 H's, C, 50 H's, D, 100 H's.
Okay, Tpot equals lambda TSLI. So 1 times 10 hours divided by 0.2. That's 10 divided by 1/5, which is 50 hours. Answer C.
Nicely done. Question 3. A tumor has Tpot of 5 days and TD equals 20 days. What's the cell loss factor? A, 25%, B, 50%, C, 75%, D, 80%.
Pi is 1 minus Tpot, TD. So 1 minus 0.25, which equals 0.75. So 75%. Answer C.
Perfect. Last one. Question 4. In head and neck cancers, when does accelerated repopulation typically become significant during conventional radiotherapy? A, 1, 2, 6, 7 weeks.
We talked about this. Is usually around that 28-day mark, so C, 4 or 5 weeks.
Exactly right. Good review. Now, looking ahead, what are some of the ongoing challenges or advances in this area?
Well, a big challenge is accurately measuring these parameters, especially Tpot and GF, non-invasively in individual patients before or during treatment. Biopsies only give you a snapshot, and can have sampling errors.
So we need better ways to see kinetics in real time.
Ideally, yes. There's a lot of research into advanced imaging, like specialized P tracers, think FLT, PTT, for proliferation that might give us a better window into tumor kinetics dynamically, in vivo.
And molecular markers.
Yeah, finding reliable molecular signatures from biopsies or even blood samples that strongly correlate with proliferation rates or the risk of accelerated repopulation is another active area.
Yeah,
The dream is really personalized scheduling based on individual tumor biology.
that makes sense. Being able to reliably predict which tumors will undergo rapid repopulation would let us select patients for accelerated therapy much more effectively.
Absolutely. It would move us beyond just relying on, say, tumor site or stage as proxies for kinetics.
Okay, so let's quickly summarize the key definitions one last time.
Sounds good. Labeling index, Li, is the fraction of cells in S phase.
Potential doubling time, Tpot, the theoretical doubling without loss, is lambda times Ts over Li.
Growth fraction, GF, is the proportion of cells actually proliferating, G1S, G2M.
And cell loss factor, phi, quantifies loss, 1 minus Tpot over Td.
And the big picture is that observed doubling time, TD, is usually much longer than Tpot because cell loss phi is often very high.
And crucially for us, rapidly proliferating tumors, those with high Li and short Tpot, can undergo accelerated repopulation during long radiation courses.
Which is why we consider shortening the overall treatment time for them using accelerated fractionation.
These concepts are really fundamental, aren't they, for understanding how tumors behave and how our treatments work?
They really are. Getting a good handle on tumor kinetics helps explain so much about tumor growth patterns and response to therapy. It definitely informs better treatment planning.
Absolutely. Well, that wraps up our deep dive on tumor kinetics. Remember, you can complete practice oral boards over at radonsmartlearn.com.
And be sure to subscribe to Rad Onc Smart Review for our next session. Thanks for tuning in.